I think one of the themes for this panel conversation is that we have three folks who are representing three different societies, and they're going to talk to us a little bit about their own personal mission and that they've been on, and also some of the work that they've done in collective societies. And I do think it's a good example to think about this broader. So I'm going to start with Jeff on the side, and why don't we just work our way down for introductions. Talk a little bit about yourself and a little bit about the organization that you're...
I'm Jeff Oestreicher. I am a pediatric ER doctor at Cohen Children's Hospital. I also chair the American Academy of Pediatrics Gun Violence Initiative here in New York State, along with my colleague Nina Agarwal, who is here somewhere today. There she is. We represent roughly 5,000 pediatricians across New York State, and we advocate at the clinical, local, state, and federal level for evidence-based, strong gun safety laws and programs. And we have had significant successes in the last year, small successes, but successes nonetheless. We have passed roughly 7 gun violence prevention bills in New York State over the last year. We've secured a little bit of funding, $250,000 from New York State. And the way we've done that, and you sort of mentioned this during your talk, is that we have tried to depoliticize the issue completely. We talk only about gun safety, and we believe in responsible gun ownership, but we do believe in the right to gun ownership, obviously. Models for that have been, we sort of think to when we faced an epidemic of crib deaths in the 70s, the CDC mobilized, was funded generously to find the causes and the solutions to that problem. And we started talking about the Back to Sleep campaign. We talked about crib safety, and SIDS rates plummeted. And no one ever accused us of talking about crib control. And likewise, we've talked about cars at length today. And when we faced an epidemic of car deaths in this country, we did not ban cars, we simply did research and we made them safer. And we sort of think of those as models to approach gun safety in a non-political and evidence-based way. And policies that we sort of are, as Dr. Rosenberg said, we don't have a lot of evidence, but we do have some. And so some policies like extreme risk protection, things like safe storage or child access prevention, we do have some evidence for, and we, which I hope we can talk about more today. And
we'll come back to that. So, thank you very much. Robert, do you want to introduce yourself?
Thank you. Yeah, just delighted to be here. I'm Robert McLean. I'm the president of the American College of Physicians for this year, which is the largest specialty organization in the country behind the AMA. I think Sue is here. And the ACP has, for many years, really had a strong history of policy and advocacy, looking at a lot of different issues and trying to put them in a public health perspective, and gun violence is really clearly one of those and tops on the list at this point. Personally, I'm in New Haven. I'm an internist and rheumatologist by training, so I'm just across the sound. But the ACP, I think, has tried to, in most of their policies, really use an evidence-based approach. As people have already mentioned, it's a problem that we don't have enough data and research within the gun violence area. However, despite that, we have really put forth a number of policies in the last decade or more, and in fact put out a call to action, which I think we'll probably get into a little bit more in a few minutes, but I'll stop there.
Great, and last we have Ruth Waldbaum. You want to introduce your background and a little bit about your organization?
Okay, but first I'd like to say I would like to thank Northwell for inviting me, because I'm in a room with many people whose research and writings I have learned from. And just one comment about Dr. Rosenberg being jealous of Michael Dowling's Irish accent. I'm really jealous of him being able to talk for a solid hour with not a note at his side. I have a pile here. So I am here as the founder of Doctors for Gun Safety. And my background is I was a pediatrician for many years with a specialty in endocrinology. And after many years, I wanted to fulfill a passion with psychiatry. And when psychiatry became much more scientifically based is when I made my switch. And I trained then an adult, child, and adolescent psychiatry. Our group Doctors for Gun Safety, and again, we were very politically minded when we said safety, not control. We didn't want red flags. Is a grassroots organization of physicians. We're non-political and not-for-profit. And our objectives are, as everybody here, is education and advocacy and support of really solid research. But my personal involvement here came after my dismay when Sandy Hook, there were no policy changes. And I would just like to remind everybody in the room that in 2 days from now will be, I believe, the 7th anniversary of the Sandy Hook shootings. And so that was so disturbing to me and to many people in this room. And then I had the thought, if any of my children or grandchildren were victims of gun violence, I would never forgive myself for not have established a voice. And I think I'm here to show that even a small group that began in Northwell, we were able to gain some momentum and to fulfill some of our objectives, which really is to educate the population of doctors, many of whom are really naive about the problems of gun violence. And doctors, medical students, other healthcare workers. And we have an amazing opportunity because, as Mike Dowling mentioned, I think it's grown to 72,000 employees. We have a large group of people that we can reach out to. And even though mandatory topics online that we swipe quickly to read are important, I think more important would be grand rounds and conferences that we have where we can interact with the staffs and educate people. Having somebody like Jeff Oestreicher, who is a professional in the ER and trauma, his personal experiences, and even my personal experience is in a private practice of psychiatry with gun-related issues, which I encounter. That kind of intimate interaction. And our objective also would be to move out into our community, more town hall meetings, and also to maintain our education by meeting with people from the military and the police and even gun owners. I have learned a lot by speaking to some of these people. So our objective is outreach, and coalition is so critical. I was thinking of this last year. There was a march in New York, and I would see scattered in little corners some doctors in white coats, 5 or 6, with a sign that said Mount Sinai or Columbia. And I said, where are we? We are a force that needs to be brought together, because in numbers there's definitely power.
So let me jump on that a little bit and maybe throw it at you, Jeff. And so first of all, we have no gory pictures, and had I thought of it, we could have had a few. We have a psychiatrist, an internist, and a pediatrician. I'm not sure what pictures we could show you, but be very thoughtful people staring at the problem and looking at the data very intently. Dr. Tepperman, I'm going to need to borrow some of your slides next time. But Jeff, you tell me a little bit about, because I think this is a moment in time where the healthcare providers, and not just physicians, but nurses, PAs, ACPs, are shifting from sort of this, oh, this is awful, to action. And tell me about your shift, because you do shifts in the emergency room, but talk a little bit about going from the sort of despair to action, and how that happens, and how can we create more of that?
I think what is interesting about being at an event like this and talking in between breaks and stuff is that everyone has their moment where they found the issue. Mine specifically is I was very naive when I was a fellow pretty recently. We're a level 1 trauma center, and of course we see children who come in with gunshot injuries, and I knew nothing about the issue. And as a fellow, we try to do a study on pre-hospital intervention in pediatric firearm injuries. So what was happening in the pre-hospital setting for kids who were shot. And we try to get the EMS data for these kids who are shot, and it is a much longer story than I have time for today, but essentially we were blocked from getting the data on account of politics, which blew my mind. I knew that that guns and firearms in this country were an intensely political issue. I did not know that the Dickey effect, the Dickey Amendment, I did not know anything about that, and I didn't know that it had a sort of a sinister effect that not only affected CDC and NIH funding, but it trickled down to medical centers and hospitals and medical schools. And sort of that's what prompted me to reach out to the AAP, frankly. And I did a lot of I just went up to Dr. Rosenberg at break like a groupie at a rock concert. And I told him that he's a complete hero of mine, because I do think that to fix this issue, I think that one of the more critical things is that we have to align with gun owners. We have tried so hard with small successes to include NRA members and gun owners in our American Academy of Pediatrics group. And what is so inspiring about Dr. Rosenberg is that the story of him and Jay Dickey sort of finding common ground near the end of Dr. Jay Dickey's life is incredibly inspiring and very possible.
Let me turn to Robert and ask you, I guess, two questions. One is there a personal journey for you in all of this? And two, I mean, you are heading up one of the nation's largest physician groups, and this issue of creating advocates within your group and also outreach to other organizations and health systems and other specialties. So two-part question.
Yep.
Your personal journey, and then using the platform of the American College to both change the people in your society and also touch other societies and advocate broadly.
Yeah, so my personal journey, I would say that I had been involved in ACP policy development for a number of years.
That's where we first met?
Exactly.
We first met at
and so I kind of learned it through some of the experts that helped kind of drive that policy within the ACP. And then living in Connecticut, the Newtown shooting was just overwhelming to the state.
Absolutely.
And you always knew somebody or somebody who knew somebody. So suddenly across the state of Connecticut, there were these remarkable personal connections that had not existed. As an internist, I had always seen patients occasionally who had a family member who maybe had some sort of residual injury. Mm-hmm. It had not hit close to home as much as with the trauma surgeons, my gosh. And so within that context, I kind of became more committed. I'd say within the ACP, so the ACP has always had, as I said, this public health concern. And there was a policy paper probably a decade or so ago. Then after the Newtown shooting and the kind of evolution of more and more of these events, the ACP put out a call to action in 2015. And similar to the one from earlier this year.
The last major paper that created the stay in your lane, that
so
was
the statement was a
2018.
year ago. So that was, so there was a little bit of an update, and I kind of would defer to Sue on some of those details, that we updated it. It came out a year ago. It was in response to that paper that the NRA put out the tweet, stay in your lane, and then, as everyone knows, kind of the explosion of physician response, and which I think was really eye-opening to a lot of us, that there really is a grassroots of physicians that are concerned about this. And it's not just organizations.
Right.
And so while the ACP has dealt with it at a large organization level, so let me take a step back real quick. So 2015, there was a call to action, actually got the American Bar Association as part of that consortium. A whole host of groups signed on, 10, 20, 30, 40, I can't remember in the end how many signed on to that. Nothing happened.
Right.
It's unbelievable. So then, fast
It
forward
seems like
this
there
year,
is this energy and then
exactly
the follow through.
And everyone's kind of doing all this stuff, and there's more and more shootings. And then this past August, we decided to put out another call to action. And I should say that had been in the works for probably 6 or 9 months. And we were getting several of the other organizations to sign on, need to get all the wording exactly right, between these big organizations, lots of thinkers in the room, and different issues for good reason. And then there was that weekend in, I think it was the end of July, when there were 2 mass shootings in one weekend.
Yes. Yeah.
And that event told us in the ACP to say, we can't wait. we have to do another, we have to get this moving. So we kind of got on the horn and spoke to a couple of the other leaders who just hadn't kind of gotten around to signing on. And literally we got the agreement, and it came out the next week. So that was that second call to action, which had 7 organizations. I should say that since that time, another 35
What are
have
some of the
signed
big
on.
organizations that have signed on?
So the big 7 were it was the American
the
Medical
American
Association,
Pediatrics.
American Pediatrics, AAFP, I think the American Public Health Association, American Psychiatric Association, and then since then 35 more across the board. I think there's a prosecutors organization. I mean, it's a huge list. The Gifford Foundation, a
Health
whole lot.
systems?
I don't know.
Okay.
Mr. Dowling, did you guys sign on to that? I don't know.
So we
But
have
it's a
to
very
think
good
about
point.
that.
And I think to a point that was made earlier, that call to action is extremely simple, straightforward, kind of advocacy, high priority. What's the simple stuff that we know would work?
Right.
Universal background checks. Banning high capacity.
High capacity, yeah.
So it's trying to depoliticize it. And say, how can you not agree with these things? You know,
Sure.
the universal background check is like the parachute argument. You know,
Yeah,
we
yeah.
don't have data, I don't think, but how can you know,
Dr.
argue?
Tepperman, thank you. Yes.
Yes.
So why don't we shift gears a little bit, since we have a psychiatrist with us, and I want everybody to chime in on this. This interplay of mental health, and there's sort of a blame game that goes on, and there's a misperception, particularly around mass shootings, I think, and other things. I don't know, Ruth, do you want to start us on this, given your background? What is your group's thought on this interplay, and where is it that we can intervene in your mind?
Okay, so the NRA, when they list the causes of gun violence, starts with mental illness, mentions criminals, producers of violent movies and violent video games. They never mention guns.
All right.
And we know that worldwide, the incidence of mental illness is approximately the same. 1 in 5 in the United States, 1 in 7 worldwide. So why is it that we have the largest number of gun violence
I think
deaths?
this was Dr. Tepperman's point about England, where
Yes.
the special case of a gun shooting.
Yeah, I mean, the numbers, even though you've seen a number of slides about that, I just want to repeat it. A recent study, out of 100,000 people, in the US we have 11.2 deaths. In Canada, 1.9. In Germany, 1. United Kingdom, 0.2. And Japan doesn't even make the list.
Right,
And these are
right.
peer nations. So they've missed the boat in terms of the mental illness issue,
Being the
because
issue.
it is erroneous, given the statistics of mental
let
illness.
me turn to Jeff for a second on children, and maybe you can interface a little bit in
Yeah.
children and the issue of adolescence and depression and anxiety at home. Is there, and that's more on the suicide thing, as we've heard, 60% of gun violence is actually self-inflicted. And Jeff, are you seeing this in the APA and what you're doing?
We are, and it's been cataloged nationally that pediatric specifically firearm suicide rates have skyrocketed over the last 10 years. And I defer to Ruth on pediatric suicide, but I do know that when we see children come in, the most common suicide attempt method, for example, is swallowing medicines or pills or drugs, and we almost never lose a child to that method, the most common attempt method. 90% of all people who attempt suicide survive, but the opposite. We talked about the flipped statistics of firearm suicide. 90% of people who attempt suicide with a firearm commit suicide. And so what we talk about are, and especially in children where suicide tends to be extremely impulsive. It's not the person for months and months and months thinking about ending his or her life. It's the child who gets broken up.
The moment,
It's
the gun
the
is
child
available. The gun
whose
is not available.
girlfriend breaks up with him and in that moment decides to kill himself. And so if they have access to lethal means in that moment of crisis, they are much more likely to die. And so what we talk about with the AAP is that we need to decrease their access to lethal means in that moment of crisis. And that's That is why
the
we talk about
interventions of
things
locking the gun,
like
separating
safe
the bullets.
Exactly.
Yeah.
Safe storage of firearms, child access prevention laws, and things like extreme risk protection orders.
Thank you. I know we're running out of time, but you sound like you want to say one quick thing, and I want to ask Robert one last. I got one last thing and another one last thing. So go ahead,
So
Ruth.
with regard to mass shootings, it's been shown that a greater predictor, particularly in childhood, of success with gun deaths and suicides is the presence of a gun. Doctors are less able to diagnose their patients' predictability for suicide by guns. But the presence in the home, and certainly your profile is actually right, but there is a misunderstanding with regarding to mass suicides and mental illness, because in fact, the studies do not verify that the majority of mass shooters are mentally ill. We haven't had the studies yet. There are only, as of September 2019, there were only 313 mass shooters deaths versus 40,000. So we don't know that information. But what we can do because mass shooting, it's really important to say this, that it has evoked the greatest response from all of us, because mass shootings occur in schools and houses of worship and sporting arenas and movie theaters and even on military bases. We have been pulled into this. We have forgotten the communities that have been dying by gun violence and just minority access to guns. But I think perhaps by getting us involved, that we're feeling it personally, the mass shootings will trickle down to these communities that have been ignored for a long time.
Exactly, and I think there's some parallels to the HIV advocacy that helped minority communities that were not able to advocate. I'm going to ask Robert to kind of close with us, because the theme for this panel was physicians getting active, joining their societies, and then those societies combining their efforts to try to attack this problem. Any last thoughts about how the ACP activates their base in this space, and, and how do we work together as health systems to work with your societies to continue to activate our provider base?
So yeah, I think the having high-level activation of organizations, of health systems is critically important. One of the things that I didn't yet mention is, in addition to advocacy, there's also the education standpoint.
Yeah.
And not only is it education of our patients that this is dangerous and a problem, it's educating our physicians and other clinicians that they need to bring this up, as had been mentioned earlier. And the ACP has some educational programs or information out there trying and actually pushing physicians to say, we should do this. You should be asking your patients, especially if they have kids or elderly or someone who's potentially has cognitive issues as they get older. Do you have a gun in the house? And if you do, is it stored safely? All those kinds of things. That is a responsibility that physicians need to start to take on, because access to the gun is the big problem.
And I would take once you set that platform, it's the systems, the health systems that need to put systems in place to help assist with that. Just like we do the PHQ-2 for screening for depression, and everyone that walks through our door, perhaps there's an equivalent in gun safety. I know there's a lot more people want to say. I'm getting a look from the great Dr. Battinelli, and he's much larger than I am. And
I just have one thing I really need to say.
Well, what can I say? It's Dr. Ruth. I mean, really. I mean, how can I say no to Dr. Ruth? So go ahead, Dr.
Yes.
Ruth. You're not Vestheimer, you're Waldbaum, though, right? Yes, go ahead.
So we constantly see public safety announcements about opioids, about drunk driving, and smoking. I would like to see somebody with influence in this audience that puts out a statement that says, safe storage of guns will save your children's lives. We need to be there on a big network, an ABC or CBS. We need it.
You snuck that in, and I appreciate that. And I just want to thank our panelists, first of all, for all the work they do on a day. These are our frontline doctors taking extra time out of their day-to-day life. This is not their job, but let me tell you, they're working almost the equivalent amount of time on this issue as they are taking care of their patients. So a round of applause for our panelists.